next 2 to 3 years. Okay, thank you. Another quarter. In many ways, what I'll be saying is I very much want to be working with you. We have a resource that the mHealth Alliance that I work with to try and support exactly these sorts of country programs. Just to go through this very quickly, just to say the obvious, there is a huge number of cell phones. There's now actually over 1 cell phone per person on the planet. Extremely misleading in lots of ways, but in most countries in Africa where we're actually working, there's very sizable, between 1/3 and 1/2 in most rural areas that we're working. As many of you will know, there are 3 different main sorts of cell phones. The basic cell phones from which you can just do voice, SMS, and a weird thing called text menus. Then the majority of cell phones currently out in Africa are what are called feature phones, where you can do some data collection, some basic internet, and then the smartphones are the top more or less 10% in the continent. And that number is going to increase greatly. The next few years, as we're talking about innovation, the cell phones are going to, and that's the area that's going to expand. There are a very large number of areas where mHealth can be used in healthcare. And there is I don't know if you know that. Yeah. There is a huge amount of interest, in many ways a lot of hype, around the use of mobile in healthcare and health now. Thank you to the organisation Gartner for putting it together. There was first a great wave of enthusiasm, then quite a lot of cynicism when many of the initial projects didn't work, and hopefully we're starting to work out what really does and doesn't work to make it more productive. If I can say, thank you, feel this. mHealth by itself isn't health innovation. An SMS by itself doesn't change someone's health, but it absolutely can play a strong role in increasing access to the interventions that we know work, to increase effective coverage, by overcoming some of the failure to follow guidelines, the issues of stock-outs we're going to hear from Davis, of increasing demand for services. There is now a framework for mHealth that has been developed by the World Health Organization, working together with Johns Hopkins University. And as this shouldn't really be an eye test, on the next slide, to pull out the different areas that they are talking of in the slide previously. These are the 12 main sectors, and there are now methodologies and examples in all of these for how mHealth can be used in different areas of healthcare. On what we are talking about, around support for iCCM and community health workers, frontline health workers, the areas that I think is worth considering here are that there are well-developed systems for patient registration, MoTech and others, for assessing patients, for monitoring patients, and there are several different systems in different parts of the world. I'm quite extensive on that, including on work planning. So it's clear what supporting the health workers is the task they have to do, up to what to keep order. The fact that the great majority of people have access to these tools allows us to think of these systems reaching the general population, supporting health, understanding, demand-seeking behavior, increasing digital awareness. My closing slide. I'm here at this conference to basically say the mHealth Expert Learning Program that I work with is available to support projects like UNICEF and others in countries in Africa and elsewhere, linking with the experts that have experience in developing these programs. So if we can work with you to see how to do these things at scale, I'd be delighted. That's what I'm here for. Thank you very much.
one place to the next. And what you'd end up with is stacks of paper with very relevant data, by the way, at district headquarters and also at the ministries of health, that nobody's really taking the time to analyze and go through and develop any knowledge out of that. What we eventually end up with is a situation where someone has stacks and stacks of information, and information that they actually needed, but do not have the time or the resources to be able to go through it all, and as a result, they're never able to get the knowledge out of it. So what we're looking at strengthening is that cycle between data collection, analysis, and usage, because that's where we can then arrive at actionable interventions to some of this data that we're collecting. And we need to make each of those processes smooth as we go along. And that's how we ended up with MTrack. What MTrack aimed to do was provide a technology means to be able to strengthen that cycle of data collection, analysis, and also usage. So what we did was come up with some very relevant indicators that were of interest to the Ministry of Health and community health workers that we then packaged into a worksheet that you can see over there and found a way to code it so that it's easy for the health worker to send these messages. And the community health worker uses their own phone. What we have also done is that we have equipped each of the district health teams with a computer and an internet connection. And the main reason for that is it allows them to view this data that's coming through. So the information flow would look very much like you're saying. We'll have information coming through from the community health worker, through servers based on the ministry. The district health teams can be able to view this data on the dashboard. And what we then did is we went out and trained each of these community health workers on how they could be able to send this data through by SMS. In some cases, you even have to be as basic as showing them how can you change from letters to numbers on your basic phone. So you have to make sure that it's very thorough. You have to make sure that it's peer-led, that they are dealing with trainers and tutors that they can relate to, that understand what some of their challenges would be as far as mobile is concerned. And in that way, you can be able to reach out to them. So the community case management supplies amongst the community health workers. We have also been able to build into MTrack a way that we can poll these different community health workers. So we can be able to, in no time, get different views and opinions on whether they have functional cold chain fridges at their nearby healthcare facility, or whether we want to find out what their thoughts are on supply volumes. And what we have been able to do is to expand this to be used by 10,000 community health workers in phase 1, and we're looking to expand that. We're currently looking at 70% reporting rates. And what we have noticed is that the success of this entirely depends on massive collaboration between various stakeholders from the Ministry of Health at the district level, at the health facility level, and amongst the community health workers themselves. And without that, that's possibly not going to happen. So what we are trying to achieve is a shift from just getting data, getting knowledge out of it through analysis, and making sure that it's actionable to the people that need to use it. So you have to be keen on the visualization and disseminating this data.
Entrepreneurial community health worker organization who didn't get their visa. So to anybody who was in the HR session earlier today, there's a tiny bit of overlap, but I tried to keep it at under a minute just so that this presentation would make sense to people who weren't there. So today I'm going to talk about the opportunities and challenges for a private sector micro-entrepreneurship model to deliver iCCM. And this discussion is based on our experience in Uganda in building such a model over the last 6 years or so. So we're a small, early-stage social enterprise, and we're still learning a lot, but we want to share with you some of what we've learned so far. I thought I was getting a lot of time. This is my failure. Okay, I'll turn. So what is a micro-entrepreneurship model in community health? Well, as a lot of you know, and we've talked about a lot at this conference, two of the biggest challenges that the community health worker community focuses is how to motivate CHWs, and then how to sustain the cost of supporting the CHW network over time. And the micro-entrepreneurship model tries to address both of these challenges by offering a third way to have motivated CHWs who don't have to be sustained by costly salaries. turn creates more product pull for the other products that they sell. So it creates kind of a virtuous cycle between the health and the sales work that they do. Living Goods, in turn, gets a margin from the products that we sell our community health workers in wholesale, which helps us to cover some of the costs of operating our own network. So it's meant to be a financially sustainable, or highly financially effective, and hopefully eventually financially sustainable way to deliver iCCM. So does a micro-entrepreneurship model work? We just wrapped up a 5-year randomized control study that JPOL conducted that helped us answer this question. And very preliminary results are showing a 20% or greater reduction in under 5 mortality rate in the treatment areas where we operate. So we are having some impact. And currently we're having that impact at about $3 per capita, so $3 per person served. And when we get to scale, we think that we can bring that down to $1 to $2. So that's promising. But micro-entrepreneurship models, as well as most private sector models, rely on charging for services. And this is a key challenge that we've talked about today in the conference that limits access and equity. So this question gets to the core of the roles of the public versus the private sector. And as a private sector innovation, the micro-entrepreneurship model seeks to reach as many people as cheaply as possible, which frees up public sector resources to reach the poorest of the poor. So in other words, we seek to maximize coverage, but not equity. And we try to do the job of the private sector so that the public sector can come in and do their own job. So by reaching as many people as we can for $1 to $2 per person, the public sector has more resources. In addition, the micro-entrepreneurship model can create a platform through which subsidies can be delivered cheaply. So we've experimented a bit with giving vouchers to some of the poorest customers in our community and allowing them to see treatment from our CHWs for free. We haven't completely figured out that system, but it's something that we're continuing to experiment with. And finally, the public and the private sector models don't have to be mutually exclusive. About 30% of our community health workers in Uganda are also part of the government community health worker network, and we think that that actually works quite well together. So why is now a good time to be excited about private sector delivery models in community health? First, increasing ability of technology to lower the cost of delivering some of these services. And we've heard a lot about technology from both of these folks.
Essentially, I'm presenting on some work that Prop Design did. And they looked at community health workers in both Uganda and Senegal. And what they did was called user-centered design. And we believe that it's very important because essentially it focuses very much on designing systems based on the end user, so the people within it. And so we focused on community health workers. And I'm sure you've seen this sort of model in your handouts. Essentially, we see this as the framework which puts community health workers at the centers, and it looks at not only just the things that they need, but in terms of tools, but also the other actors involved in the system, the design principles around it, and what we're actually trying to do. And it shows it on their journey from sort of recruitment all the way to being able to have a career path. So some of the findings that we had was that the tools were not really working together. The job aids, for example, are not connected to other tools. They're not connected to commodities, etc. So we're trying to build an integrated approach and information into tools and diagnostics, devices, mobile services, but also really the commodities. And this doesn't exist, but this is what we like to try to aim for. Now, another thing was transportation. And the needs around this really vary a lot and are very different between different kinds of CHWs. They have, education, they're going to different places for follow-up, yet their storage bags are not. Okay, this is really hard. Okay, so this was around designing a system which doesn't put the drugs right out there, because we're seeing that people want drugs, but we need to be really looking at diagnostics first. Third thing is data. And around data, the registry books are very, very big. The digital data reporting systems are very complex. And we really need to to create these feedback loops, which send information back to CHWs and actually help them assess their own performance, and also be able to show the community the impact that they're having. The fourth thing was really some observations around training. And once they are trained, they usually feel like they aren't adequately supported. They're asked to do a variety of things, and what we would really like to see and move towards is this sort of recognition and trust that they need to have, and to be constantly trained. We really see that mobile systems are a way to train them. Fifth was around incentive programs. There's no structure or progression or growth, and being a community health worker doesn't really feel like a career path. This really leads to a long-term motivation problem. And we think that there needs to be sort of a clear recognition of the work that they do, and there's a lot of opportunities to do that. But also, there's a lot of opportunities around payment for services, mobile payments, and the data to show who's performing well, who's not, and offer them a career path within that. The last thing is obviously on supply, and none of these things are new. But I do think that looking at it from a community health worker's point of view can point towards what can be done and where the opportunities are. And I think sort of this slide really harks back to Nina's point about how we need to work together. And we think very, very much of just the public sector and the private sector, but it's actually all combined. So that was it. We will move on to the panel now. And I have some questions for